Hello, I'm Dr. Sridhar. Welcome back. We have reviewed the basic aspects of high frequency ventilation, and now we will discuss the practical application of high frequency ventilation in clinical practice. So, we have to make a decision of whether we need high frequency ventilation. Some units use it as a primary modality, especially in the extreme premature babies, but most of us use it as a rescue modality. Early rescue is a better lung protective strategy similar to early surfactant therapy, and it can be considered as an early rescue in RDS where you have a high pressure or oxygen requirement, meconium aspiration syndrome with a high oxygen requirement, and in this setting we may have PPHN as well. So remember that the FiO2 target depends on whether there is PPHN or not, so echocardiography is important as well. We may have primary modality in air leaks, and if the lung is collapsed and is not responding to conventional ventilation, you may use high frequency to open up the lungs. In pulmonary hemorrhage as well, it may help as a rescue modality. When we decide on high frequency use, we have to decide on what settings you'd keep, and that depends a lot on what is the nature of the underlying condition and whether the recruitment is indicated or not indicated. So we will discuss that as well. When we transition from conventional ventilation to high frequency as a rescue modality, there are a few key points to remember. Understand the nature of the underlying condition. The strategy depends on the disease condition, which we will discuss. The current pressure differential, the PIP to PEEP, should be considered. The mean airway pressure applied during conventional ventilation should be noted as well. Remember that high frequency depends on the tube being patent and not having a significant leak. So make sure there is a suction, and also try to connect a closed suction in this situation. If there is a significant ET tube leak, you may consider an elective tube change if the baby will tolerate. The hemodynamics is very important because during the recruitment stage, you will be over distending the lung. You may have a drop in the blood pressure. So you may need a little more filling volume. You may consider a bolus if the blood pressure is on the lower side, or if the echo indicates that the filling could be better. We have to correct the acidosis and transfuse the baby if needed. So a baby on high frequency usually indicates a sickest baby, so your transfusion criteria would be among the most generous transfusion cutoff. So for example, 11 to 12 grams would be a cutoff in most of the babies with this situation. The chest x-ray and blood gas should be reviewed at regular intervals to monitor the progress. We do have sedation indicated, and at the start of the high frequency you can use a slightly higher sedation or a bolus, but wean it down quickly and try to allow the baby spontaneous respiration. This becomes more important as recently our thought process has changed. Even in high frequency, the ability of the baby to have the spontaneous PEEP and the gas exchange support provided by the spontaneous breathing helps to reduce the tidal volume needed during volume guarantee ventilation. So don't knock down the baby like we used to. Keep the sedation levels low. This has a big advantage. You don't use paralytic agents anymore with high frequency. You don't use midazolam, which has a lot of fluid redistribution problems as well. So remember these when you start high frequency, and you have to change your approach with the modern concepts as well. Lung recruitment is not indicated in diseases like pulmonary hypoplasia, congenital diaphragmatic hernia, where there is a air leak and PAE, and in established bronchopulmonary dysplasia. So in these conditions, your approach to ventilation is going to be different. You will use a relatively lower frequency. The tidal volume may need to be higher, and you would need an inspiratory-expiratory ratio of 1:2. You need more time for expiration, and also the less pressure damage to the rest of the lungs. In BPD, actually, it's not the first choice. It's not easy to manage a baby with BPD on high frequency, but you can use it to tide over at a time when there is atelectasis of the lung. This is a very useful figure, and it shows you the frequency range you target according to the disease. So where there is established lung injury, like in BPD, you have increased resistance, reduced elasticity, a longer time constant, and the babies tend to be bigger. So you would be having a frequency of 6 to 8 hertz typically. Where the lung compliance and resistance are variable, and time constant is relatively longer with the larger size baby, like in meconium aspiration, you would have 7 to 10 hertz as the preferred frequency. In diaphragmatic hernia and in term baby with RDS, the time compliance is reduced and the time constant is short, but the babies are bigger. again you would keep 9 to 11 or so. In lung hypoplasia, there is a reduced compliance, but there is a high risk of volute trauma. So again, you would keep 8 to 12. In RDS and early PAE, you would go for higher frequencies. The smaller the baby with RDS, the higher, like 15 to 20 hertz can be used for babies 1 kilo and below. The smaller the baby, the higher the resonance frequency, and so babies may do with the lower tidal volume as the frequency goes high. And this has been demonstrated in many studies by Dr. Luna. So in non-recruitable conditions, we should avoid overdistension. Very important. That's why the Wiki trial on diaphragmatic hernia did not show a benefit of high frequency, because they tried to use a higher map to recruit. Use high frequency to maintain normocapnia, but with low tidal volumes. So you can accept a little hypercapnia as well. These babies are often hypoxemic, and you have to adjust your oxygen targets accordingly. And most of the time it's PPHN associated, so your echo becomes important. Use the chest X-ray to assess the lung volume and the FRC, as your oxygen cannot be a good marker in these situations. Avoid recruitment maneuvers and avoid a map more than 15 if possible. And where the recruitment is considered, it's usually the low compliance lung, stiff lungs like in RDS, meconium aspiration or pneumonia, pulmonary hemorrhage, and so on. So these are the typically surfactant deficient, either primary like RDS or secondary as in meconium and pneumonia. These conditions have a short time constant, and we prefer a higher frequency as tolerated. The smaller the baby, the higher the frequency you can go to. And because the meconium aspiration is usually in the bigger babies, your frequency would be 8 to 10 hertz. So this is again from the article I mentioned in the beginning about lung recruitment. So where you clearly indicate lung recruitment in these diagnoses, you start off with determining the target frequency according to the weight of the baby and the condition, and the saturation range you would accept. For example, on RDS, you would want a saturation range around 30% and below, while in meconium, you can accept a slightly higher saturation, and if there is PPHN, you even accept a target which is the FiO2 target will be higher. Saturation range may be similar, 90 to 95, but the FiO2 target you accept will be different according to the condition. Commence a high frequency at the chosen mean airway pressure and observe the saturation. If it is immediately weaning, then there is no need for recruitment. The baby is responding to high frequency well. And this is one of the reasons why some authors like Dr. Anton suggest that you would start at the lower map than what you have on conventional, even these settings. So mostly we say if you are on 10 map on conventional, you go to 12 map on high frequency, like 2 more. But Dr. Anton suggests that you start with 8 to 10 even with these situations, so that you don't have a risk of over-distending if the baby is a quick responder to high frequency. So you start with 8 to 10 map, and then anyway you're going to increase by steps of 2 centimeter every 2 to 3 minutes in RDS settings. And in bigger babies, you wait for 5 to 10 minutes, and in BPD, you may wait for 10 to 15 minutes. So you don't make acute changes in these babies because it's a heterogeneous lung disease. The baby is bigger, it needs time to redistribute. So once you increase the map by 2 centimeter, if the saturation starts improving, reduce FiO2 and your pressure is appropriate. If the saturation is below, then you increase the map again in steps. So quicker steps of 2 to 3 minutes and steps of 2 to 3 map increase, and in a bigger baby 5 to 10 minutes. You continue this until there is no improvement in SpO2 for 2 to 3 steps of map. So if you have increased map of 4 to 6 centimeter and still there is no change in the FiO2, that means the oxygen requirement is due to heterogeneous lung disease or shunting, and your increase in pressure isn't going to serve any purpose. It may actually over-distend and damage the lung more, as you may cause iatrogenic PPH. And so step back in these situations, you accept the oxygen level and you do this scanning and other things to check whether anything more could be done. You also have the peak pressure reached, and this is the stage when the recruitment is completed. The next step is to find out the pressure of closing and the optimal pressure. So for that, you start with the Pmax and maintain the lowest FiO2 that you have accepted for this baby. Then you reduce the map by every 2 to 3 minutes or 5 to 10 minutes and observe the saturation response. So the approach is similar to what we discussed. The bigger babies, you allow more time. Do not increase FiO2. Reduce FiO2 if saturation is more than the target. If saturation is less than the acceptable minimum, we have reached the closing pressure. Do not wean further, and immediately increase the map to the Pmax. So you want to re-recruit the lung. You don't want the baby to have a relative period of hypoxia. and also excessive oxygen exposure than needed. So you go back to Pmax, then wait till the saturation returns to the target range to re-recruit the lung, and then you are going to use the principle of hysteresis to drop it, and you would aim to stop at a level of 3 to 4 centimeter above the closing pressure. So this is the completion of the open lung strategy. So for that stage in disease, you have noted down the peak pressure, the Pmax, the closing pressure, and the optimal pressure. But remember that this can change from time to time. So if there is any fluctuation, you may need to repeat the recruitment process. For example, you have disconnected the ventilator, or you're transporting the baby, or anything else that happens, secretions have clogged the tube, you may need to re-recruit, and each time the lung situation may change, so your pressure may not be the same every time. You can use that as a target, but then you have to consider changing it as well. So we discussed this already. Maximize the cardiovascular stability, treat pulmonary hypertension as appropriate, consider sedation. Here it's a very carefully worded, only consider, don't over sedate. Position appropriately, suction with the closed suction if possible. Monitor the carbon dioxide, because it's very easy to wash out carbon dioxide with high frequency, and as we know, hypocapnia can cause increased risk of periventricular decomalacia, and over distension itself causes iatrogenic pulmonary hypertension, and this reduces perfusion to the brain as well. So remember that multiple factors are involved. You should be very careful when you handle such sick babies. Adjust the delta P throughout and according to the carbon dioxide monitoring. If you are on volume guarantee, this step will be obviated. So this is from Dr. Anton's talk, and this is Emma Children's Hospital in Netherlands. Here it's the same. The lung is closed to start with. In this situation, they have used before surfactant was given, but if you are doing early rescue, you would be after the surfactant is given. So the pressures that you need may be lower than what is described in his studies. So you open the lung to reach the Pmax, then you drop it till you start seeing a rise in the FiO2 and the saturation drops when you have reached the peak closure again. And then you reopen and drop it to 3 to 4 centimeters from that level, which is the optimal pressure. So you don't want to maintain at the maximum level, which used to cause the previous problems with distension and hypotension and so on. You just want to maintain in the optimal level using the principle of hysteresis as we discussed. So this is the pressure volume loop. We have the initial pressure, we have reached the P open or the P max, then we have reached the P closure, and then we increase it back to P max and drop it down to the optimal range. So it's a range, it's not going to be one number, but obviously you want to keep it in this optimal range. And if there is any maneuver that causes de-recruitment, educate your team to re-recruit the lung before coming back to this level again. So what is the FiO2 PaO2 target that you would use? Ideally you would use 0.21, but you may risk over distension in healthy lung units. So in RDS we can aim for less than 0.3, and in heterogeneous lung disease like BPD, meconium aspiration, you would accept more, 0.4 for example. So you would stop the recruitment when you reach this FiO2 according to the condition. And if there is PPHN, the FiO2 may be accepted at 1 and aim for the best possible PaO2. So according to the disease, not every baby with PPHN needs 100% oxygen. Obviously, if you are able to oxygenate reasonably well at 60 or 70%, so it's a higher oxygen than what you would accept in other situations if you have PPHN. So this illustrates what their experience was in terms of the pressure needed. So they started with the MAP of 8 and the FiO2 of 0.7. They reached a maximum pressure of 21 in majority of the cases, and the FiO2 dropped to below 30. And then the pressure could come down to 12 when the saturation started drifting. Then they opened the lung again and they came to 2 to 4 above this closing pressure, which is 14, and the FiO2 was still maintained. So this is their example. It doesn't need to be this high, as high as 21 if you have given surfactant already, and again in a bigger baby you may need a higher pressure, even 24, 25. So there is no absolute limit, but have a closer eye, and if you start exceeding 20, you consider doing an X-ray and make sure you're not missing anything like an air leak.